Okay, it's working. Thank you everyone for coming. It's a pleasure to introduce Dr. Renee Bender. Probably well known to many people in this room. Dr. Bender is a full professor in our department, has been a longstanding faculty member, ran our inpatient psychiatry unit for many years, among other things, and still comes up to cover a couple times a year, which is much appreciated. She started our Psychiatry in the Law, colloquially known as the Forensic Psychiatry Fellowship Program here at UCSF in the 80s? 2000, more recent, okay. And was also more recently past president of the APA. So, and besides that, has been a wonderful and appreciated mentor to me over many years. So without further ado, thank you for coming today.
Thank you, Andrew. So as Andrew mentioned, I ran the inpatient unit, really starting in the 1970s. And believe it or not, in those days, a patient would come in, they were put on a hold, and we could keep them there. They could appeal their 5250 by going to San Francisco General, and some of them did go to those hearings. And while I was on the unit, we started to have what now are called probable cause hearings. It used to be called Doe v. Gallineau hearings. And then we started to have the Riese hearings. And my perspective, and the patients' rights advocates would come on the unit and talk to the patients about trying to get them discharged. And my perspective was, why are these people here? And what are they doing? And we're just trying to treat these people, and they're trying to get in the way, and that none of this made, any sense, and they just have no business doing that. And that was my perspective for a while. And and to some extent, when I cover on the unit, I think it's still people's perspective that all of these groups are basically a nuisance, and it would be much better if they weren't around. And why are there so many people where we can't put them on hold, and their family members come to us and they're homeless and they're in the community. And so what I'm going to present today is just a slightly different perspective, because what I have learned is there are very good reasons for civil commitment laws. There are movements, certainly in this state and around this country, to make it easier to put people in the hospital, to try and take them off the streets, to institutionalize them. People talk about how psychiatric mental hospitals should not have been defunded, and if only we had state hospitals, we'd be back to the good old days, and they really were not the good old days. So, okay, my disclosure. So let's start out just with some of the ideas behind civil commitment. So a man comes into the emergency room. He is a very high-powered CEO of a company, and he has crushing chest pain. He has enzyme changes. And so the people in the emergency room say to him, "You're not going anyplace, sir. You have to go up, you're having a heart attack, and you have to be hospitalized on the CCU, or else you're going to die. And in fact, there's 1 in 10 chance that unless you come into the hospital, you're going to die." He says, "I don't want to come into the hospital. I have a really important board meeting. There are millions of dollars dependent, millions and millions of dollars, and just give me something and I am leaving." Okay, can he leave?
Yes.
Why?
You can't help someone.
He has the capacity. He knows what the risks and benefits are. He knows he might die, and he still wants to leave. Goodbye, sir, and we wish you well. On the other hand, a woman comes into the hospital. She says, "I'm really, really depressed." Her family brings her in. She is suicidal. She says, "I want to die, but I don't want to come into the hospital." We say to her, "You're at very high risk of committing suicide. We can treat it, or at least give us a chance to treat the underlying depression." Can we put that person in the hospital? Same thing, 1 out of 10 chance of death. Can we? So this CEO can leave who might die, but this woman, we're telling her, it's not your choice. You need to come into the hospital. Or just another example, a gang member comes into the hospital. He's just been cut by another gang member, and the only thing he says is, I want to get out and get him back. Can we keep him? Maybe. Does he have a mental illness? We could say intermittent explosive disorder, or maybe antisocial, come up with something, but he doesn't really have a mental illness. And we're not here, there are a lot of dangerous people out on the streets. Unless they have a mental illness, we really can't keep them in the hospital. Okay. So it's very, very different, and we're taking rights and institutionalizing a certain group of people, whereas we're not a whole other group of people. So the legal basis for civil commitment is, first of all, you can only hold someone if you're legally allowed to do it. And is the person dangerous? How sure are you? You don't have to be 100% sure to say they have a mental illness, but you have to say something. It can't just be, this person is very, very angry. And the issue is there a mental illness? Because again, if there's no mental illness, a clear cut, or at least sort of clear cut, we cannot hold that person against their will. So does anyone know who this is? This is sort of the poster boy for civil commitment. Anyone know who this is? We know who John Hinckley is. He's the one who tried to assassinate Ronald Reagan. Those people from New York may know who Son of Sam was, who did these serial killings. Do you know who this person is? Okay. So this is Andrew Goldstein. Buford Borough did racially motivated crimes in Southern California. So Andrew Goldstein was a man who had chronic schizophrenia, was in and out some of the state hospitals, in and out of the state hospitals in New York. He wanted to be in the state hospital because it was much nicer in the state hospital on the street. And so he had just been told, well, when there's a bed, maybe we can get you in, but you don't really meet the criteria for us putting you in a state hospital. So he goes to a subway station in New York, and he's looking around for something to do, and I heard his confession after he does the crime. And he sees this blonde woman, and then he kind of looks at her and says, no, not her. And then he finds this other woman who's just standing on the subway platform. Her name is Kendra Webdale, and he pushes her in front of a moving train, and of course she dies. He is, everybody sees it. The police come, and he says, now will you take me to the hospital? So this is the basis of Kendra's law. Kendra Webdale was a young woman, I think she was in her 20s, who came from the Midwest, who came to New York, never really rode the subways, but she was riding it because she was on a dinner date, sort of the kind of person that was very appealing, and he didn't even know her, he just chose her. And her parents went to the legislature, it became a huge thing, and it was the development of Kendra's law. Similar law in California is called Laura's law. And Kendra's law is the basis of outpatient commitment in New York when there was outpatient commitment, assisted outpatient treatment in California, very, very similar to Kendra's law in New York. The ironic part of it is that Mr. Goldstein would not have been put on an outpatient commitment on the basis of Kendra's law. In fact, he wanted treatment. He wanted to go to the hospital, but that was used as the basis. The same thing for the perpetrator of the victim of Laura's law would not have been holdable under the criteria of outpatient commitment in California. And in fact, he had been evaluated shortly before he killed Laura at an outpatient mental health clinic. Police went to his house. He didn't meet the criteria for 5150. He said, I don't have guns, I'm not going to bother. He was actually targeting a social worker in the clinic where Laura Wilcox worked. And the last words out of Laura Wilcox's mouth before she was shot, she was a college student who was just working there over the summer, was, he's here, you better hide. And unfortunately, she was shot. So he didn't have the history that you need in order to be put on an outpatient commitment, assisted outpatient treatment in California. So let's just look at the history of involuntary treatment. So this is a quote: the number of persons distempered in mind and deprived of their rational faculties has increased greatly in this province. Some of them going at large are a terror to the neighbors, which are daily apprehensive of the violences they may commit. So let's have a vote. When was this written? How many people think the 20th century? The 19th century? Okay, 18th century? 17th century? Okay. Benjamin Franklin, in 1751. So what Benjamin Franklin was saying was he wanted there to be a psychiatric hospital built in Philadelphia. There was one that was built, and in fact it only recently closed down. And so he was trying to appeal to the legislators and saying, we have all these violent people, we better have a psychiatric hospital to put them in. When I hear about this, I'm reminded some of the arguments after there's a mass murder, which of course the person who's likely to commit a mass shooting is an angry young man with a gun. That's the typical prototype of someone. But what you'll hear is everyone saying, we need more we need more money for psychiatric care. This is a mental health issue. Even though it stigmatizes people with mental health, I know it was hard for me when I was president of the APA to say, no, we don't. No, that's not the issue. Because of course you want more money, it's always a good thing, but that's not going to solve the problem. The issue of people on the street has been around for a very long time, especially since the treatment has moved from state hospital to the community. But here's another quote. The right to restrain an insane person of his liberty is found in that great law of humanity, which makes it necessary to confine those whose going at large would be dangerous to themselves or others. So it was written by Supreme Court Justices, how many people think 69? 56. 1845. Okay, 1782. So the Massachusetts Supreme Court said it in 1840. Again, the same issue. What are we going to do with these people who are clearly psychiatrically ill? So what's the legal basis for involuntary hospitalization? There's really two criteria. One is parens patriae, which means that society has a responsibility for those people unable to care for themselves. It's a very patriarchal, a very paternalistic idea. Parens patriae means father of the country. And that if we see people in need, we have the responsibility and the authority to provide services for them. And then police power, the authority to prevent harm. And governments do have police power. We always want to make sure it's not abused. But there are certain things, there are laws, you have to ride a bicycle, you have to have a helmet, for a bicycle, for a motorcycle, seatbelt laws, that we have the authority for even if people want to hurt themselves, the authority to try and prevent it. So there is legal reasoning against involuntary treatment. So the Constitution prohibits detention of a person against his will without procedural or legal safeguards. And this is a really good thing, right? We're in the United States, you can't just pick people up and throw them in jail or throw them in hospitals. Privacy rights, which means you can't touch someone. People have the right to be private. The Eighth Amendment, which has to do with cruel and unusual punishment, and the Fifth and 14th Amendment, a due process requirement when confinement is at risk. You can't just pick someone up. There has to be a whole process, which of course is how we get into the hearings and the court hearings. Now, there has been a lot of abuse of civil commitment. So in yesterday's New York Times, there was an article about Charles Dickens. It was in the first section, kind of midway through, and I thought, wow, this is just what I'll be talking about tomorrow. So Charles Dickens, who we all love, apparently in 1858, he separated from his wife of 20 years, and he had an affair with a young actress, Ellen Ternan. And what the article said is that letters were found which explain that he was very unhappy with his marriage. She had borne him 10 children, and she had lost many of her good looks and was growing old. That's what the letters said. And he tried to put her in an asylum, a psychiatric hospital, with assertions of his wife's, the word that they used was languor, which basically said fatigue, taking care, I'm sure he didn't do too much to take care of the 10 kids. And also excitability, and that this showed, and this was the key term, moral insanity. And Dickens had a friend, a psychiatrist, Thomas Duke, who happened to run a private asylum. So he called up this guy and said, I want my wife put away. And to his credit, Thomas Duke refused to hospitalize her. But what the article said is there were an awful lot of Victorian physicians who would have hospitalized her, that basically women were property. If your husband said, off to the hospital, he was sent off to the psychiatric hospital. I mean, after all, you had all these kids, and now you're a little tired taking care of them, and you're not as attractive either. And then Dickens wrote about this psychiatrist, and he called him, this was one of his best friends initially, a wretched being, and he was a medical donkey. Okay. And then there was the story of Mrs. Packard in 1864. So in Illinois, there was a statute that provided for commitment of married women by their husbands, quote, without the evidence of insanity or distraction required in other cases. So he put her on a railroad and sent her off to the psychiatric facility. Some historians think that this is the origin of the word to be railroaded. And she was there for 3 years. And when she came back, she was really angry. And she was partially fought to change these laws. And then, of course, in more recent history, we have the whole history of Soviet dissidents, that in the old Soviet Union, there were these terms, ambulatory schizophrenia, and it basically meant that you had political beliefs that were not consistent with communism. And some of those people were also put in psychiatric hospitals. So civil commitment in the 50s and 60s, you needed underneath the doctrine of parens patriae, you need treatment, you don't know it, we're going to put you in treatment, whether you like it or not. You were presumed incompetent after civil commitment, so at the same time as you were hospitalized, a lot of your rights were taken away, and in fact, you had to go to probate court to be able to write contracts, to be able to enter into any kind of agreement, any kind of civil competence. Then we have the 1960s, which was, of course, the civil rights movement for minorities and women. And then we started to have, in 1967, rights for juveniles, because also parents could stick their kids wherever they wanted in any facilities. And so there was a landmark case which required due process for juveniles, and that set the stage for civil commitment reform. Then in 1969, California had the first civil commitment statute. We call it the LPS. Did anyone know who Lanham and Petra Short were? I know, their name is on the legislation. So they were 3 legislators. Mr. Lanneman, Mr. Pesters, Mr. Short, and they wrote this legislation. And there was a move from parents patriotic. We think you need to be in the hospital by whatever criteria we have you have to be dangerous. And dangerousness being some kind of reason, and you also have a mental illness in order to be in the hospital. In 1970, there were other cases, Wyatt v. Stickney. This came out of Alabama. So people were being put into the state hospitals there, and they were just being warehoused. So there was a Supreme Court decision that said, if you're depriving someone of liberty, you also need to provide treatment. And the decision was written, you have to have a certain kind of nutrition every day, 3 meals a day, you have to have a certain space around your bed. It was very directive. But again, there was this whole movement of civil rights, and that just because you have a mental illness doesn't mean that you don't have rights. In 1972, Lessard v. Schmidt, she was committed in Wisconsin, and due process rights were established for civil commitment, including you have to have mental illness and you have to have dangerousness. And this statute said it has to be beyond a reasonable doubt. So it's like if someone is convicted in a criminal case, they really have to be dangerous if you're going to take away their rights. This is no longer stands in any place. The standard right now is clear and convincing evidence, which people said it's probably a good compromise. To have to prove it beyond a reasonable doubt will have a lot of people out of the hospital who really should be there, but you need a little more than just 50%, so it's more like 75%. And there are serious consequences of civil commitment, including stigma. In the decision, they say that they quoted some research that said employers would rather hire an ex-felon than someone who was civilly committed. There were other cases that went through the Supreme Court having to do with how should we use civil commitment. So the requirements for civil commitment are you have to have a mental illness, you have to meet the criteria of dangerous to self or dangerous to others. In 3/4 of states, it's also gravely disabled, not in every state. So if you ever practice in any other state, you have to see what their statute says. And grave disability is defined as it is in California. I mean, sometimes the wording in the statute is a little bit different, unable to provide food, shelter, and clothing for yourself. And then there has to be some degree of treatability, that you can't just warehouse people if you're gonna put them in a psychiatric hospital. But there's also been a whole movement that people have the right to refuse treatment. And again, this was a different perspective for me, but when you think about it, you say, thank God we live in the United States where we do have these laws and these Supreme Court decisions. So in one case, the quote was, this is Justice Cardozo, every human being of adult years and sound mind has a right to determine what shall be done with his own body. Good idea. In common law, individuals who touch another for the purpose of treatment without the patient's consent are guilty of battery, which means that you have to pay money, civil damages, and you can even be put in jail. Of course, patients have a right to refuse surgery. They have a right to refuse chemotherapy. I mean, if someone comes in and they have advanced cancer, which is treatable, the family can try and convince them to get treatment, but we can't force anyone to take treatment. Patients have a right to refuse medications based on religious beliefs. So if you're a Christian Scientist and you don't want a transfusion, even if the doctors think that you're going to die, you can refuse it. And there are all kinds of constitutional issues. So it's really a balance of interests, which is what civil commitment is all about. So the family has interest, the state have interest, which is to restore mental health for the patient's own benefit, safe institutional functioning. This is also one of the things that when you're looking at it from the perspective of the state, that if you have an institution, you have to keep the institution safe. You don't want to keep people in restraints all the time, so you have to medicate them so that other patients and the staff are safe, and then also cost saving. So it's certainly better to have 7 days of hospitalization than 6 months versus patients' rights, where the disability rights, patients' rights say that people have the right to autonomy, to privacy, and a liberty interest. And it really is a balancing of those two. So can involuntarily hospitalized patients be medicated against their will in non-emergency situations? Can they?
Yes.
Who said yes? If it's a non-emergency?
I guess
Up on the inpatient unit, patient is refusing the medications.
well, if it depends on if they've been deemed competent or not.
Right, right. But let's say they haven't had a Riese hearing yet.
Okay.
Can they be medicated?
No.
No, until they're deemed incompetent. So there's an interesting movie called 55 Steps. I don't know if anyone has seen it. It has a good cast. It didn't get a large distribution, but it has Helena Bonham Carter, who plays Eleanor Riese, and then it has Hilary Swank, who plays her attorney. 55 Steps refers to the steps of the California Supreme Court, where it wound up not being heard. They kept the decision of the lower court. But she said, I can walk up the 55 steps. Anyway, that's why they called it. So it used to be, you were brought into the hospital and you could not refuse medications. When on the 72-hour hold, it didn't matter whether you were competent or incompetent. Once, just by being hospitalized on an involuntary basis, you could be given medication. So you can see that people who are involved in patients' rights advocates, they were looking for an ideal case to try and reverse that, where the facts of the case would be very compelling. And they found the case of Eleanor Riese. So Eleanor Riese, when it's Riese versus St. Mary's, they're talking about St. Mary's on Stanton Street. I mean, this was a local case. So Eleanor Riese had chronic schizophrenia, and she did well on Mellaril. This is what it says in the court decision. They don't use the generic names, which is thioridazine. So they called it Mellaril from 1969 to 81, and she really didn't need hospitalization. So this is before the days of atypical antipsychotics. The advantage of Mellaril is that it did not cause extrapyramidal side effects. The disadvantage was that it caused a lot of anticholinergic side effects. So, people had orthostatic hypotension, they had a very, very dry mouth, and sometimes dry eyes. And the other thing is, you could only use it up to 800 milligrams because otherwise it caused terrible, cardiac arrhythmias. So you could use Mellaril up to 800 milligrams. And she was on it, and she actually did very, very well. And in 1981, she developed bladder problems secondary to long-term Mellaril use. And so people changed her antipsychotic, and nothing really worked. And she kept on being rehospitalized because, once the medication was changed. During her 1982 hospitalization, she was placed back on Mellaril. And what the chart notes say about it is, because they didn't know what to do, they said, well, her bladder's damaged anyhow, so what difference does it make? Again, if you're a patient's rights attorney, you're looking for a case like this. It just doesn't sound very good. In 1984, she was put on Molindone, which was was popular for a few years, again, before the atypicals were introduced. But it was mid-potency, similar to, really in between like haloperidol and chlorpromazine, but it just didn't work. So she stopped her medications and decompensated and needed rehospitalization. And the basis of the lawsuit was the 1984 hospitalization. She was admitted as a voluntary patient with acute exacerbation of chronic schizophrenia. She signed an informed consent for meds, and she was tried on Moban, on Narvane, and then Mellaril. She complained that the Mellaril was causing dizziness, again, causes terrible orthostasis because it had a lot of anticholinergic side effects, and dry mouth, and she said, "I think you've given me too much medication." She became agitated and refused medication, so she was forcibly injected, and she was put on an involuntary hold. On the involuntary hold, what they wrote was she's delusional about her medications. She thinks they cause her dry mouth, and perfect thing. She was switched to Narvane, given Narvane IM when she refused a PO. She complained that the Narvane caused dermatitis and swelling in her ankles. And she agreed, if you just stop the Narvane, okay, I'll take Mellaril. And then she was put on a conservatorship because she was delusional about her medications. And she was unwilling to accept voluntary treatment. These were the criteria that they put on the conservatorship. She was discharged to a boarding care home. Again, she needed readmission. Her meds were changed to Serentil. That's very similar to Mellaril with orders for IM. Again, she complained of swollen feet, urinary problems, shaking, memory loss, seizures. And the notes say she's obviously delusional. So, disability rights, patients' rights said she's not delusional. This is a perfect case to say, even if you're psychotic, and she was psychotic, you still can know something about your medications, and it doesn't mean that medications can be forced on you. So the court said, patients may be involuntarily committed, yet remain capable of giving informed consent. And then they also said, and the courts, in a lot of the courts, have an anti-psychiatry bias. And this is an example. Treatment with antipsychotic drugs not only affects the patient's bodily integrity, but the patient's mind, the quintessential zone of human privacy. And the task for the court is to determine whether a patient refusing medication is competent to do so, despite his or her mental illness. So this is why we have the Riese hearing on every patient, because of this decision. That just because someone is dangerous to themselves, danger to others, or gravely disabled, does not make them incompetent. And if they agree to medications, that's just fine. But if they're refusing medications, before you can medicate them, you have to have a Riese hearing. The similar thing in the prison, they call it a Kahia hearing, but you can't just medicate people just because the doctors think they know best. Again, as doctors, we find that offensive, but the courts are saying that, yes.
How exactly do they define emergency?
Okay, so in the decision, it says a medical emergency is an exception, and it's an exception to the whole principle of informed consent. Medical psychiatric emergencies justify involuntary medication, hospitalization, seclusion and restraint. You don't need a patient's consent for this when less restrictive environment is not appropriate. So let's just take this example. A patient, and this actually is an example from the inpatient unit. So the patient had schizophrenia and an acute exacerbation, also had amphetamine intoxication, had positive symptoms, so hearing voices, and delusional, and a history of violence to staff while previously hospitalized in the state. This was a well-known patient who would come in after shooting meth, acutely psychotic, and had assaulted staff. So the patient came into the unit and started to make verbal threats, started to become agitated and not responding to behavioral intervention. So the nursing staff would say, you need a timeout, you need to go to your room. Here's a PRN medication. The patient said, I'm not taking any PRN. Okay. Patient has not yet become assaulted. So there was an emergency staff meeting about whether this constituted an emergency or not, and whether the patient could be given IM meds because they were refusing PO meds. So, do you think that this is a medical emergency? Raise your hand if you think it's a medical emergency.
Wait, did you just say the patient was not yet?
Not yet vital.
Okay.
He banged his hand, his fist on the nursing station. He was clearly becoming agitated. Nursing staff were also becoming concerned about it. And that's why there was a meeting. Because some people said, this person is escalating. We need to give them some medication. Other people said, wait a minute, with the Riese decision, it's only if the patient is assaultive, we can't give it to them. So there was a meeting. So how many people think that that medications can be given, that this is an exception to Riese? Okay, and how many people think no? Okay. And the argument for no, patient has not yet become assaultive. Let's just look at the definition of an emergency in Riese. And years ago, we used to have this in the nursing station. An emergency exists when there's a sudden marked change in the patient's condition so that action is immediately necessary for the preservation of the life or the prevention of serious bodily harm to the patient or others. And it's impracticable, that's the word, and the decision to first obtain consent. So, it was interesting because a lot of the staff and some of the people, who just responded think it's not quite an assault and maybe we shouldn't do it. You have to look at what the intent of the decision. In the Riese decision said, if someone is about to attack someone or they're about to, you don't have to wait until they actually do it. In those cases, you do give emergency medication. But when you can wait, you should wait because the person has the right to refuse. So, you have to document, I'm giving the person IM medications because this is an emergency, there's a sudden marked change in the patient's condition, it's my belief that action is necessary for the preservation of life or to prevent seriously bodily harm. But this clearly fits within that. And so there shouldn't be confusion about that. When it's defined as a medical emergency, you can medicate the person. It's just when it's not, the person can refuse.
But it seems like in the emergency department, they can hack the patient, they can give them the meds, they can do that. And on the inpatient side, it seems like it's a harder process. Not that they're not allowed to legally, but the actual physical action of giving the meds IM. It takes longer to make that decision.
Well, if it's understood the intent of the Riese decision, it shouldn't be hard. Of course, it's hard to give IMs and people get hurt, patients get hurt, staff get hurt, so you have to know what you're doing in terms of giving the person and making sure that nobody gets hurt, working in a team, and all of those things. Okay, so what are patients' reactions to involuntary treatment? And there haven't been a lot of studies about it. Some of the best studies have shown that when people feel coerced, they don't like it. But positive pressures they like a lot better. Persuasion, inducements, high respect, concern, there's lower perceived coercion. Which makes sense. You want your kid to do something, you can bribe them or give them positive reinforcement. That often works better. Everyone is going to feel better about it. And when you hear, there are some bills right now in the California legislature to broaden the criteria for involuntary commitment, trying to make it easier to bring people in. And the argument that's used is, and there are people who will come forward and say, I was forced into treatment and I don't know what was wrong with me. I am so thankful because I took the treatment and now, please, it was really a good thing. But the opposite is true also. And a study that was done showed 50% felt forced medications were a good idea, 40%. And some of the people who were involved in patients' rights advocates, they'll tell you stories. They were a teenager and their parents put them in an institution, and it was just the worst experience of their lives, and they don't want to see it happening to other people. So it's not really clear-cut. The thank you, is not always the response. It is the response of some people. we did a study up on the unit where we put people in seclusion, and then as they were getting ready for discharge, we gave them a questionnaire, and we said, how did you feel about being secluded? And we compared it to other experiences, because both of them were on involuntary hold, being transported to the hospital by the police, the whole idea about being on an involuntary hold, the whole idea about being in a psychiatric hospital, comparing to the experience of being in seclusion. And about 2/3 of the patients felt that seclusion bothered them more than other experiences surrounding hospitalization. And what I thought was very interesting was 50% of the people had no idea about why they were even secluded. And the reason why that's interesting is because it's standard operating procedure that you say to the patient, this is why you're being put into seclusion. You check them in a few minutes. This is why you were put into seclusion. This is what you need to do in order to get out. But I guess when you're just so agitated and you're just in the room, you don't even notice it. Or some people don't. They don't even hear what the staff are saying. There are proposals about having proxy decision makers and advance directives. The idea being that when people become competent, when they're no longer psychotic, that they should have an advanced psychiatric directive that says, if I ever become manic again, please, I'm damaging my life, I'm spending all my money, I'm ruining my marriage or my relationship, please put me in the hospital. And that people should do that at the point when they're competent. Sounds wonderful. I mean, the problem with it is that then the person comes into the hospital, you show them the advanced directive, and they say, I'm revoking that. I don't want that right now. Or the other problem, there was a case out of Vermont, Hargrave versus Vermont. So this woman who had been hospitalized had a psychiatric advance directive, and the person that she put as her proxy decision maker, healthcare proxy, was the patient's rights advocate. So she becomes psychotic again, and the parents, the patient's rights advocate says, she told me she doesn't want to be in the hospital, doesn't want to take medication. The parents get very upset. They say, what are you talking about? This is our daughter, she needs hospitalization. Patient's rights advocate isn't her healthcare proxy, we're her parents. But she had designated that the person she wanted to make the decisions was the patient's rights advocate. So it went all the way up to the Vermont Supreme Court, and they said, if the whole idea of a healthcare proxy is you decide what you want done and who's making the decision. If she wants patient's rights advocate, it doesn't matter what the parents want. So you kind of have to be careful what you wish for in terms of what it will say in these. There are malpractice claims related to involuntary treatment. There are claims about false imprisonment. If you're going to put someone in seclusion, you need to document. I mean, now we have all these forms, and it's you pretty much have to document it. But there has to be some kind of a good reason. Where, of course, we always have good reasons, but where a third person is going to read it at some point, that it's pretty clear that least restrictive interventions were used before that, and that was the only thing that was indicated at this point in time to prevent harm to self or others. And involuntary treatment, like you said, the person was psychotic, and they really weren't psychotic. And I've been involved, in some of these cases. The person should have been on the allegation they should have been on a neurological unit or something like that, and they were put on a psych unit. But you just have to go through the records and see that it seemed to be the best place. Because if a person is very agitated, neuro usually isn't going to take them. There are also malpractice claims, more malpractice claims associated with failure to institute involuntary treatment. The most common cause of malpractice, do people know what it is in the United States? Psychiatric malpractice.
Patient who commits suicide?
Yeah, suicide. Yeah, that's the most common thing. So, the issue was, in all of these cases, you have the parents who just lost someone or spouse, who lost someone, and they're saying this person was clearly suicidal, they should have been hospitalized. And so they bring it to a consultant to review. The consultant was their suicide risk assessment. Did anyone even think that this person could be suicidal, and then make an informed decision about what the right thing to do. Failure to diagnose or treat, and abandonment. Okay. So what to do if a person needs hospitalization or if they're suicidal? You first have to understand the legal and ethical principles. Again, the criteria for involuntary treatment are a little bit different in each state. So you have to, wherever you're practicing, and of course in California, it's danger to self, danger to others, and grave disability. There is a duty to protect a statute that if someone makes a threat to hurt someone else, that there is a duty to try and protect the victim. You can discharge that duty by informing law enforcement and making efforts to contact the potential victim. But another thing you can do is to hospitalize the person. The principles of informed consent, the principles of confidentiality, when it's okay to deprive liberty, when an emergency situation is defined, and that you can give involuntary medications, you can hospitalize people, you can do all sorts of things, but only when the emergency continues. With all malpractice, the issue is documenting what you were thinking and how you balanced the rights and benefits, the risks of it, and then the benefits of it, so that it was a judgment call. And that's why you did what you had to do. No one afterwards is able to second guess you. I mean, they may try, but it never holds in a court of law, as long as there's a pretty good documentation. And whenever you have questions legally, to get consultation. And that's incredibly easy when you're working at Langley Porter and you're on the inpatient unit, there are tons of people around. It's a little bit harder if you're in private practice. You call people, they're not available, you have to make a quick decision, but it's really important to do that, and certainly supervisors. Family members are an incredibly important part of making decisions. I get calls from residents in the emergency room when I'm faculty backup, and whether they should release someone, they want to release someone, and the family member is saying, no, we don't want to take them home. We're concerned that the person is suicidal. Doesn't mean you're going to hospitalize them, but you better think really, really hard about it before you let them go. You need to find out what the exact concerns are of the family member and help alleviate the concern. Because if the patient does go out and does something to someone else or themselves, remember it's going to be the family members who are going to bring the lawsuit, and they're going to say, I told the doctor didn't listen to me. So, when a family members often know much more than we know. They don't always. Patients aren't honest with them, but sometimes they do, and at least you need to listen to it and evaluate it. And if you're going to go against family members, you better have a very good reason and have consultation before you do it. So I'm going to stop there so that I can leave time for questions about civil commitment. Yes?
I was really struck by how many of the case examples were women plaintiffs. And so I'm wondering if you could speak to gender bias within involuntary confinement and involuntary medication, as well as race and class biases.
It is a wonderful question. I'm a past president of the California Psychiatric Association. The California This is not a secret to the people in the CPA who are really pushing bills for Moore's Law. I mean, they were behind it for all kinds of involuntary commitment. And I am very aware of the research related to it. And there is a lot of research out of New York that says that outpatient commitment, Kendra's law, is applied much more to African American patients than it is especially to white patients. Now, the advocates say we're talking about a population that has chronic schizophrenia, that's homeless, that maybe doesn't have access to care, and that will wind up in hospitals, and that's why outpatient commitment is applied to those segments of the population. So that's the counter argument. We developed a resource document and a position statement where this is from the American Psychiatric Association, where we spoke about it and we said that basically the research is unclear. But when you're applying it or thinking of applying it to populations who have a lot of other social factors, you have to be aware of this, how it's perceived by those populations, especially that you're taking people's rights away, that you're locking them up. It's not just how anyone would respond to it, but a population who already has a history of incarceration, slavery, whatever, that you have to be super sensitive. I think some of these cases that have wound up, I'm not sure, you're right, a lot of them are women. My theory is, again, if you're a lawyer, it's not the people themselves who are bringing it, they have to find good lawyers, that they find articulate, verbal, women who are willing to do this and really fight for their rights. But not all the cases involve women, and there are a lot of landmark cases that involve men too. Yes?
So what's your perspective on SB 1045?
Why don't you explain what that is?
So it's Scott Wiener's housing conservatorship bill, where folks who are homeless for more than a year and 5150'd 8 times or more in 1 year, but generally cannot be conserved because maybe meth plays a high role in their acuity, it would expand the capacity to conserve them mostly as outpatients.
Again, it's weighing different sorts of things. If someone has been hospitalized that many times, that's a different story. Outpatient commitment, Laura's law, Kendra's law, is not that controversial when it's used to extend hospitalization. So someone who has been in an acute hospital multiple times, and then they're getting ready for discharge, and they're just going to come back, to put them on a conservatorship is not that controversial. And in fact, in New York, where the best studies have been done, most of the cases of putting people on assisted outpatient treatment, now some people think that's a euphemism, assisted outpatient treatment, that should be outpatient commitment, but anyway, that most of the cases have been that. The time that it's controversial is when it's preventive. So someone is in the community, they don't yet meet the criteria for involuntary commitment. And you're predicting that they will, based on history. But it's rarely applied that way in New York because it's so complicated. It takes months to do it. You have to go to court. You have to get, people to see them. So it's just a really complicated process, where it's pretty easy once they're on an inpatient unit to kind of put them on a conservatorship.
Thank you.
Yeah.
I was wondering about your thoughts about how people are operationalizing grave disability. It seems like danger to self and danger to others are kind of more clear in some way, but we're getting a lot of people saying so many of these homeless people, and they're clearly desperate in dire straits. How do we go about thinking about whether somebody should be conserved because of grave disability?
So, the idea, when there have been studies about outpatient commitment, what the studies have generally shown is that, first of all, it has to be for a while. It has to be at least 6 months. So someone has to stay, in the treatment. And that the reason why it works is you're mobilizing a system around the person. You're getting them treatment resources. And that is a really good thing. That in states who have outpatient commitment statutes and there aren't any resources, no one ever uses it, because what are you going to do? You tell someone they need to go to treatment, and then you can't get them into treatment. So it's a good thing to be able to say, we are going to take responsibility for you. We're going to provide housing, we're going to provide drug treatment, we're going to provide psychiatric care, we're going to provide case management. That is a really, really good thing if you can mobilize the system to take care of a person. Some people say that if you have intensive case management services where you're really trying to engage the person, the issue is, do you need that legal leverage? And that's where the controversy is, that you need the resources and you need them applied and you need the case management. And we have pretty good resources in a city like San Francisco. I mean, a lot of places in the country have terrible resources, and that's what makes things work. And anything we can do to get people engaged in those resources and to get the resources care about this individual, to say, this person is your response, hey, resources, whether it's through behavioral health court or whatever, this is the responsibility of the system to take care of this individual. That works very, very well. And that people respond to that. We're gonna help you out, and we're gonna meet you where you are. That's the other thing. So very, very helpful. Yeah.
Can you recommend any resources for making these decisions of patients with anorexia? So kind of determining what would a medical emergency, what would constitute a medical emergency that would justify, like, medical hospitalization or refeeding?
So again, it's sort of, in the Riese decision it gives the actual wording, but it depends on the documentation. If the clinician says it's a medical emergency or a psychiatric emergency, nobody is going to say, no, it wasn't. It's kind of like, well, you're reading my note and you're saying, no, I was there. I define this as an emergency. Who knows? Someone drops down on the street and you start pounding on them. If you're there and you think that they need CPR, it's kind of like, so if there was a reasonable reason to think that this was an emergency, you're never going to get in trouble. But again, a lot of it is the documentation. In my opinion, this was a medical emergency, this was a psychiatric emergency.
A lot of times we see treatment, they'll start refusing treatment later on, like as they're starting to get more stable.
Exactly.
Makes, that justification.
Then that's a different story. And then you have to kind of work with the person. Or a conservatorship can help with that.
I'm just wondering about the logic and the legal precedent of these med consent forms that we use in inpatient psychiatry, like before starting the antidepressant or what have you, when it's obviously protected by the law from, like, without a Riese, they can obviously refuse the meds. But it seems to me that if you were to actually do like a capacity evaluation on a lot of these patients, but you're having to sign these consents that they don't necessarily have the capacity, and are those actually, is that actually a legal thing, or is it just sort of how the hospital protects itself?
It's a risk management thing. The idea being that you have to explain to a person that everyone has the right to make a decision what they want to their own body, and so you have to give them a list of what the risks, the benefits, the alternative treatments, including no treatment. But we know, it's a little ludicrous, you go to see your dentist and they make you sign a consent, you don't really read it that, if your tooth is hurting, yeah, I could die during, the extraction, but I'm not really worried about that. It's a kind of like, you assume, or when people sign into Moffitt Long, if you look at the consent form, it has all these things about students working on you. It also has things in there about some of the data being able to be used by the development office. I was shocked to find that, kind of thing. The idea that if you had Bill Gates, hospitalized, that the development office would want to know, so maybe they could, kind of approach him for some money. And I never knew that happened, but it is. It's on the consent form, and that's how you protect it, by having it on the consent. So people don't really read it. Even when you're giving consents to fly in a helicopter or to go on a climbing wall or something like that, and the risk managers tell the company, I know if I fall because it's poorly constructed, but actually you still can sue even though you say there's no liability.
It's just interesting that it's only for psychiatric meds, not like any other meds.
No, you have to give consent for all kinds of medications.
Oh.
Yeah. Well, I'm just trying to think in the hospital. No, you give consent for procedures that have to be done. Right. There's just a general consent for hospitalization. You can refuse it though, but people usually don't if the doctor thinks it's indicated. So there is a higher thing, things that have been traditionally used as tranquilizers and things like that. Again, whether it's a good or bad thing depends on your perspective. Yeah.
You mentioned the closing of the state institutions and how people are starting now to think back more fondly on that, and I've seen a little bit of both in the news, the recent closing and then the idea that the permanent supportive housing that was supposed to replace that hasn't, and you're leaving people on your own. And I'm curious what you think about which way that's going. Do you think it will swing back towards a type of state institution or more towards permanent
So
housing?
people like Hello Tori, who run the Treatment Advocacy Center, very much for involuntary hospitalization, getting people off, a lot of stuff he says is good, and some of it, I think, maybe the research doesn't support it. But when he talks about how many people are in jails and prisons versus how many people were in the state mental hospitals, and the point that he's making is as the population of the state mental hospitals went down in the 60s and the 70s, the population of jail and prisons went up. Good point. Except it's not really the comparison group right now. You have to take in the people who are in community treatment and are using other resources. I mean, if what people get out of that is therefore we should build up state hospitals. I mean, the state hospitals, we're not great places. I mean, Langley Porter, we have an old building, but we have terrific treatment. We have terrific staff, who are working here. It's still not pleasant to be there. We know about all the medication errors that happen, and people don't have freedom to do things. It's not good to be hospitalized. It used to be after you had a baby, you were in the hospital for a week. After you had back surgery, after you had a heart attack, people said the more you could get hospitalized, the better it was. Now people say, get out of the hospital. You're gonna get, you gotta get up and walk. You're gonna get hospital-based infections. It's just very unpleasant, and it's not only that cheaper, but it's also much healthier. Get the newborn mom home as quickly as possible, so that she doesn't get a uterine infection or something. So the thinking has changed about that. Okay, yes.
I'm just curious about the psychiatric advance directives. I know in California we don't have those legally yet, so just do you have any experience with?
Yeah, so the issue is, what I said is, first of all, even if somebody has that, it's used as a therapeutic tool. The person says, I don't want to come into the hospital. You say, let me just show this to you. I know, you're in a state of mind right now, and you're really scared. You'd rather use the word scared rather than paranoid, that you're really frightened. But let me just, remember we spoke about this, so it can be very, very, very helpful. But the problem with it is, what are you going to do if someone said, I want to go in the hospital, and then they're saying, I revoke that, I don't want to do it. It's like involuntary ECT. We can get a court order to do it, but we're sort of relying on the person going along with it. But we don't take people who are screaming, one flew over the cuckoo's nest, you're shocking me. I'm like, we're not going to wheel them into the anesthesia suite. We just kind of hope working with them. And again, if you give people the right to psychiatric advance directives, as in this case in Vermont, sometimes they'll say, I don't want it done. Right. But overall, it's a good idea because it forces people to engage with the patient while they're competent and say, let's just talk through what just happened and what we can learn from it together and what you want to happen next. And that's very powerful. Okay, thank you.
Thank you.